Out of all of the blood vessels that can be found in the body, the capillaries are by far the most unique type of vessels that we have. As previously discussed, capillaries are the smallest vessels in the body, and they are made up of a single layer of endothelium with a basement membrane that wraps around the vessels. The thin structure of capillary walls is what allows for the facilitation of gas exchange between the blood and the surrounding tissues. Capillaries exist in beds of about 10 to 100 capillaries. Each capillary bed will connect arterioles with venules, which will be discussed next. The general size of capillaries is about 5 to 10 micrometers in diameter. That is very, very small. In fact, our red blood cells are only about 8 micrometers in diameter, and therefore, when red blood cells are going to flow through capillaries, they actually will have to line up single file and be passed through individually. This is a nice little picture to show you this phenomenon. You can see the endothelial cells making up the capillary itself. That's this simple squamous epithelium. And then you can see the red blood cells that are existing within this capillary and their nice single file arrangement. Of all of the blood vessels in the body, it is capillaries that are the most common. In fact, our bodies contain roughly 20 billion capillaries. With such a massive amount of tiny vessels, there is an extremely large surface area that is formed by the capillaries to permit oxygen diffusion into the tissues. While there are a vast amount of capillaries that can be found in the body, capillary beds themselves will actually also retain a very, very unique and specified structure. As we zoom in on our body's microcirculation, we will come to see that there are different parts and different vessels that can be found making up our capillary beds. So we should first describe what true capillaries are. True capillaries are the vessels that we see over here. These are the vessels that are actually allowing the gas exchange between the blood and the tissues. True capillaries can be found branching off of a central vessel known as the vascular shunt, which will be described shortly. As I just mentioned, there are about 10 to 100 true capillaries that make up any given capillary bed. But it is not just the true capillaries that can be found making up our capillary beds. There are, in fact, other vessels that facilitate and regulate blood flow into and out of the capillary bed. And those are what make up the vascular shunt. So we can see much better in this picture here, the vascular shunt highlighted in the center. The vascular shunt indicates the specific vessels that will allow for blood into the capillary bed and also for allowing blood out of the capillary bed. The vascular shunt begins with a very special arteriole known as the met arteriole, and this is going to branch from our body's arteriole and allow for blood flow into the capillary bed. We'll find smooth muscle cells wrapping around met arterioles and other arterioles as well, as these are going to be places that blood flow is regulated through vasoconstriction and vasodilation. The met arteriole is a principal component of our body's vascular shunt. The vascular shunt more specifically refers to the parts of the capillary bed that direct and regulate blood flow into the entire bed. This portion connecting the arterioles to the venules is the vascular shunt, and the met arteriole is one of the major components that make this up. However, there is a second major component of our vascular shunt known as the postcapillary venules, and those can be found here. The postcapillary venules are at the end of the capillary bed, where deoxygenated blood that has picked up carbon dioxide from our tissues is going to enter into the venules. Now, it's very important for us to note that the vascular shunt consisting of the met arteriole and the postcapillary venules will not facilitate any gas exchange. This specific portion of the capillary bed does not allow for any oxygen or carbon dioxide diffusion. It is only in the true capillaries that we get gas exchange. So we can imagine, as the heart pumps blood into our major arteries, those arteries are going to continue to branch and form smaller and smaller vessels. Eventually, when they get small enough, we'll call those arterioles. And as our arteries get smaller, they become more muscular, which helps for the regulation of blood flow. And you can see that characterized by these smooth muscle cells that are going to be wrapping around the arteriole. Now, when the arteriole gets to its destination, it's going to project met arterioles, which will give rise to the capillary beds in the vascular shunt. Blood is naturally going to want to go through the vascular shunt, into the postcapillary venule through the thoroughfare channel and allow that blood to go back to the venous drainage, specifically into venules. And that's what's depicted on this picture over here. We have a direct flow of blood from the arterial over to the venule. However, there is one other element here that's going to regulate blood flow into the capillary beds and specifically allow blood to access the true capillaries. And those are the precapillary sphincters. And we can see these precapillary sphincters at the junctions between our vascular shunt and our true capillaries. Remember, it is only the true capillaries that will facilitate gas exchange. So the precapillary sphincters will regulate blood flow into those true capillaries. If we don't want to have a capillary bed perfused, we will constrict these precapillary sphincters. And when we relax these precapillary sphincters, blood is going to be allowed to flow into the true capillaries and facilitate gas exchange. So despite being the most numerous of all of our vessels and being the smallest of all of our vessels, the capillary beds will have a very, very unique structure. Each part of our capillary bed contributes to its overall function. There are quite a few different types of capillaries that will differ based on their structure, and that indicates that they will also differ in their function. The three types of capillaries are continuous capillaries, fenestrated capillaries, and sinusoidal capillaries. Each of these capillaries are slightly different in the amount of leakiness that they allow from their vascular structure. Some capillaries, as we will come to see, will permit the passage of very large things in and out of the capillaries themselves, while other capillaries are going to have much, much tighter junctions. And so each of these next three capillary types exist within a spectrum. The continuous are going to be the tightest capillaries. We will then go over fenestrated, which will be nicely in the middle, and the sinusoidal capillaries will be the leakiest of them all. So first and foremost, continuous capillaries. They are named continuous capillaries because the basement membrane is continuous. It is completely uninterrupted and wraps around the entirety of the capillary itself. So this would be the tightest capillary, or we could also say the least leaky type of capillary. We find these continuous capillaries in places that we don't need to pass large things through the walls of our capillaries. Some examples of large substances are nutrients, proteins, and cells themselves. Continuous capillaries will permit the passage of very, very small particles, such as oxygen and carbon dioxide. These are the most common types of capillaries in the body. We will find continuous capillaries in areas such as the skin and the muscles. And the reason that we find these in those locations is because the skin and the muscles don't need large nutrients or proteins in order to facilitate their homeostasis. We need to bring oxygen to these tissues to promote their metabolism. But aside from smaller substances, we don't need to get anything large to our skin and our muscles, and therefore we'll have continuous capillaries in these areas. We will also find continuous capillaries in the lungs and in the nervous system as well. Continuous capillaries don't have lots of pores for large things to pass through. In fact, means of transport through continuous capillaries is the most limited. There are these structures known as the intercellular clefts that we can find in our continuous capillaries, which are consisting of tight junctions. However, these tight junctions do tend to be a bit looser and can allow passages of substances through them. The other major avenue of transport in the continuous capillaries is penocytosis. Penocytosis is also known as bulk phase transport and was discussed in Anatomy and Physiology 1. In essence, with penocytosis, our endothelial cell is going to form a vesicle around the substances that are just outside of the cell, and then these vesicles are brought into the cell and transported across the thickness of the cell to the other side. Now, one last note I want to mention about the continuous capillaries is that I did mention that these can be found in the nervous system. However, these are not the capillaries that are found in the blood-brain barrier. The blood-brain barrier is going to demonstrate some of the tightest junctions that we can find in the body. There's no leeway for us to allow things to leak into the central nervous system. So our blood-brain barrier has to be much, much tighter than even these continuous capillaries. Fenestrated capillaries are the second type of capillary that we have. The fenestrated capillaries will have fenestrations, which give them their names. Fenestrations are tiny pores that can be found inside of the body of our endothelial cells. You can see many of these fenestrations in the endothelial cells making up these specific capillaries. We will still have the intercellular cleft where two cells come together, but here we're going to have much larger pores that will facilitate larger substances coming in and out of the capillaries. We'll find the fenestrated capillaries in the small intestines and by the endocrine glands. We have to think about what the purpose of the endocrine glands and the small intestines are. Inside of the small intestines, we're digesting food and absorbing those nutrients into our bloodstream. And as we discussed a few chapters ago, the endocrine glands have to have a very, very rich blood supply so that they can secrete their hormones into the bloodstream. And it is the fenestration specifically that allow for the larger nutrients and hormones to be transported into the bloodstream. The fenestrated capillaries are going to have walls that are much more leaky than those that are found in the continuous capillaries. But there is still one other type of capillary that's even more leaky than the fenestrated capillaries, and those are the sinusoidal capillaries. Sinusoidal capillaries are the third and the most leaky type of capillary that we have. Clearly, out of all of the capillaries, the sinusoids will have largest holes found in the cells, and also they'll have these very, very large intercellular clefts. The basement membrane on sinusoids tends to be very discontinuous. We'll have very, very large fenestrations, and the intercellular clefts will be large enough to allow for proteins and even different types of cells to enter and exit the bloodstream. Red blood cells are going to enter into the sinusoids of the red bone marrow, and macrophages and other immune cells will enter into the sinusoids found in the liver. Lymphoid tissues will be a specific location where white blood cells will be entering into the bloodstream. All three capillary types are located in different places and serve different functions based on the necessity of the capillaries in the location in which they reside. As you can see, the continuous capillaries are the least leaky. The fenestrated capillaries are a little bit more leaky than the continuous capillaries, and the sinusoidal capillaries are the most leaky out of all of these. The next major vessel that we have are venules. Since capillaries are the location of gas exchange, once blood passes through capillary beds, they will then be carrying deoxygenated blood, and that will give rise to our venous drainage. The venous drainage is made up of venules as well as much larger veins. Now, venules, as was discussed when going over capillary beds, are the smallest of all of the veins. Postcapillary venules will eventually fuse and form the venules, and the venules will start taking deoxygenated blood back towards the heart. However, many venules will end up fusing, connecting with each other, and that's eventually going to form the large veins that will take blood back to the heart. Now, as discussed in our last lecture video, the walls of veins are going to be much different than the walls of arteries. They're going to be much, much thinner, and they're going to have valves as well. Veins can be grossly identified from arteries based on the way that they look. Since veins are going to have a much thinner wall, they will not be as patent and as structurally supported as arteries will be. There will be a much larger diameter to the lumen of veins, but there's not going to be as much elastic tissue found in the walls. And this is because the venous drainage has a much lower pressure than that of the arterial tree. The thinner nature of the walls of the veins can be attributed to each of the layers of the walls of the veins being thinner themselves. The tunica intima and the tunica media are much, much thinner than that in the arteries. Out of all of the layers, the tunica externa will be the thickest, but we will not have the internal or external elastic lamina. This is going to indicate that our veins do not stretch as well. Now, since there is a larger volume, a larger lumen inside of our veins, that's going to allow blood to adapt in variations in the volume of blood that passes through those vessels, and they are much more pliable than the arteries. However, without that elastic tissue, they do not withstand pressure as well as arteries do. There will still be a bit of smooth muscle found within the tunica media, but it's much, much less than is found in our arteries. The arterial tree is going to be the major place where we will regulate blood flow and facilitate vasoconstriction and vasodilation. It is possible to regulate the size of our veins. However, regulation of blood flow by the veins happens much less frequently. Just as in the heart, the valves of the veins are going to prevent backflow. These are especially necessary as the veins are going to have less pressure. since there is a lower pressure in our venous circulation. Deoxygenated blood will often flow backwards towards the capillaries that just facilitated the gas exchange. So we have to have valves to prevent that backflow. We'll find these valves especially in the arms and the legs, where muscular contraction will aid in the pumping of blood back to the heart. You can see that this is a nice longitudinal section of our veins. This is a cusp here. You can see the cusps over here of the valves. Now, out of all of the blood in our entire circulation, the majority of it is found in our systemic veins and venules. This will be the place that serves as one of our body's blood reservoirs, and we will come to see that again in just a few slides. But in review on veins and venules are going to have much less smooth muscle, much less elastic tissue, and a much larger lumen. They're going to be much easier molded than our arteries will be, and they're also going to have valves to accommodate for the lower pressures that exist in this half of our body's circulation. One other adaptation of our body's venous drainage are called sinuses. Sinuses are veins that tend to be much larger and flatter than typical veins. They sort of resemble large sacs, and these large sacs will hold a large volume of blood. One place that we will see a venous sinus is on the back side of the heart, the coronary sinus, which will drain the coronary circulation. So this sinus right on the back is going to receive blood from all of the major veins of the heart itself, and it's going to dump that blood back into the right atrium. These are still part of the venous drainage, but they're just shaped a little bit differently than veins. One pathological condition related to our body's venous drainage are varicose veins. Varicose veins are very large and swollen veins that are caused by leaky, overworked valves. It is very important that we remember that the venous drainage is going to have a much lower pressure. So it's naturally much more difficult to get blood back to the heart than it is to allow blood to eject from the heart. Over time, if valves start to give out, blood is going to eventually flow backwards, and that's going to lead to the twisting and dilation of veins, especially in the legs and the feet. Increased weight due to obesity or pregnancy are going to produce larger pressures in certain parts of the body. Varicose veins can occur on almost any part of the body, but they do most commonly occur in the superficial veins of the lower limbs, in the esophagus, as well as the anal canal. If varicose veins arise in the anal canal, we call these hemorrhoids. One vascular structure that we find commonly dispersed throughout the entire cardiovascular system are anastomoses. An anastomosis is an arrangement of blood vessels where two or more blood vessels are either supplying or draining a particular area of the body. Anastomoses ensure blood flow to or from an area. You can see here that this arteriole is allowing blood to come out to the capillary bed. But we also have another connection shown up here, and this is the anastomosis. We can have both arterial anastomoses and venous anastomoses. These ones will be a little bit more common. Many of our superficial veins are going to be anastomosing back to the heart. Again, anastomoses will ensure blood flow makes it throughout the body. If we just had one single vessel that's carrying blood back to the heart, it is much more likely that we'd undergo some serious type of trauma if that one vessel was damaged. So having many different pathways that blood can take is an assurance policy to make sure that blood is able to get to certain areas. Arterial anastomoses are often found in joints, in abdominal organs, and especially also in the brain. Keep in mind how important it is that blood flow makes its way to the brain. Without adequate blood flow, our neurons are going to start to die. So it's very important that we have a way to ensure that blood flow gets to all areas of the brain. So there's a specific anastomosis known as the circle of Willis. This structure is a circle of vessels that is wrapping around the pituitary gland and the optic chiasm. If we were to have a blockage in one of these vessels over here, there will still be many other ways that blood can travel out to all of our brain tissue. So anastomoses are like insurance policies to make sure that blood gets everywhere in the body that it needs to. The function of anastomoses is nicely highlighted here. If one of our arteries is blocked, blood can't get to that part of the body, and that will eventually lead to necrosis, which is the death of tissue. So with an anastomosis, that gives us an alternative route that blood can get to that area. Now, as I mentioned when discussing the veins and the venules, blood distribution throughout the body is not even between all of the different types of vessels. In fact, the vessels that make up our venous drainage will contain over 1/2 of all of the blood that we can find in the body. You can see that less than 10% of blood at any given time is found in the heart, and also less than 10% will also be found in the pulmonary vessels. Even our body's arteries are not going to have as much blood in them as the veins will. This is due to the low pressure system as well as the large lumen that can be found in our venous drainage. Because the systemic veins contain such a large percentage of blood, they will serve as a blood reservoir that can quickly divert blood to areas of importance if there is the necessity for it. One example of a time when we would use this blood reservoir is during muscular activity. If we're activating our muscles, we'll need increased blood flow to those areas to bring more oxygen to them to facilitate more ATP formation. During this process, we will facilitate venoconstriction, which is just the constriction of the veins, and that's going to reduce the amount of blood in the blood reservoir and increase the amount of blood that's flowing over to our skeletal muscles. Similarly, during times of hemorrhaging, as blood volume decreases drastically, blood pressure will decrease, and that will facilitate venoconstriction, and venoconstriction will increase blood pressure. So that will help us to counteract the drop in blood pressure that was caused by the hemorrhage. The next major concept, and the last major concept that will be talked about in this presentation before we get into blood pressure, is capillary exchange. Capillary exchange refers to the process or the movement of substances between the blood and the interstitial fluid. This is the goal of the entire cardiovascular system. The exchange of gases in the capillaries occurs by 3 different methods, namely diffusion, transcytosis, and bulk flow. Diffusion, which we could more specifically call simple diffusion, is the first type we will discuss. Each one of these methods facilitates transport into and out of the capillaries in different ways. Certain substances are a lot smaller and can be transported in and out of the vessels a lot easier. However, some other things like large proteins and cells, as we saw with our sinusoidal capillaries, are going to require a much more adapted vasculature to get them to allow for their transport in and out. The first method we will discuss is diffusion. Diffusion, more specifically referred to as simple diffusion, is a type of passive transport mechanism that allows for substances to diffuse down their concentration gradients. When there's an area of high concentration of a particular substance and another area of low concentration of that same substance, a gradient is set up pointing from high to low. And the movement of substances down their concentration gradient is what we refer to as diffusion. Now, many different things can diffuse into the capillaries, and as we saw a couple slides ago, we have 3 different types of capillaries: the continuous, fenestrated, and sinusoidal capillaries. Depending on the type of capillary, that will determine what substances are allowed to diffuse into and out of those specific vessels. Naturally, continuous capillaries are only going to allow smaller things to diffuse in and out, while sinusoidal capillaries will allow much larger particles to diffuse in and out. Some of our most important players, such as oxygen, carbon dioxide, glucose, and amino acids, are all going to be substances that will diffuse into the bloodstream via simple diffusion. Naturally, as the blood is carrying oxygen and our tissue cells are using oxygen, there is a concentration gradient set up from the inside of our capillary pointing towards the tissues. There's a lot of oxygen inside of the blood and not a lot of oxygen in our tissues. So oxygen will diffuse by simple diffusion into the tissues when it gets there. And at the same time, oxygenated blood does not contain lots of carbon dioxide. However, carbon dioxide is a waste product of metabolism. So carbon dioxide will be in high concentration inside of our tissue cells, and therefore carbon dioxide will flow into our oxygenated blood as oxygen is flowing out of that blood and into the tissues. As we saw with the endocrine system, the glucose concentration in the blood is also subject to change, and that can determine the direction of diffusion that takes place for glucose. Now, diffusion can happen by several means. One way diffusion is permitted is through the intercellular clefts or the fenestrations that are found in those endothelial cells. Those large holes in the endothelial cells typically will facilitate larger substances coming in and out of our capillaries. However, there is another means by which things can diffuse into our bloodstream, and that is through the cell membrane itself. Oxygen and carbon dioxide are very small lipid-soluble molecules, so they can easily pass through the endothelial cell membrane. Another factor that determines what substances and how those substances will cross into our capillaries is whether or not those molecules are lipid-soluble or water-soluble. Just as we saw with the endocrine system, lipid-soluble molecules are able to interact with the phospholipids inside of our cell membrane, and they will be allowed to diffuse directly through the endothelial cells themselves. However, water-soluble substances, such as glucose and amino acids, will have to pass into our capillaries through the fenestrations or intercellular clefts. Steroid hormones, oxygen and carbon dioxide, are able to nicely pass through the cell membrane themselves, as those molecules are lipid-soluble. As discussed previously, large substances, such as cells, can also diffuse through the walls of our capillaries into the bloodstream. Those will require sinusoidal capillaries to facilitate their diffusion. Our second means of capillary exchange is known as transcytosis. Transcytosis only moves a very small amount of substances across the capillary walls. However, very important things do pass into the capillaries in this manner. Take a second to remember that not all capillaries will have fenestrations or large intercellular clefts to permit movement. Proteins such as insulin are water-soluble and can't cross the capillary walls by simple diffusion directly through the membrane. So we have to use transcytosis to get this hormone into the capillaries. Transcytosis is a process that combines endocytosis and exocytosis. Endocytosis is when we form a vesicle and bring something into our cell, and exocytosis is when we exude something out of the cell. So transcytosis is a combination of the two, when something enters into the cell and eventually is transported across the cell and will leave on the other side. And this is going to be how the hormone insulin is going to enter into our capillaries also. Bulk flow, which is our last type of capillary exchange, is a passive process in which large quantities of ions, molecules, and other substances will move together in a fluid in the same direction. Bulk flow is a much faster process than simple diffusion because we're going to utilize pressure gradients here instead of concentration gradients. A pressure gradient simply refers to an area of high pressure pushing things towards an area of lower pressure. There are two types of bulk flow, namely filtration and reabsorption, and both of these just refer to a differing direction of movement of substances in and out of the capillaries. Filtration refers to the movement of substances out of the blood into the interstitial fluid, and reabsorption refers to just the opposite direction of movement when substances go from the interstitial fluid into the blood capillaries. This is still considered a passive transport process, as there is no ATP that is used to make this an active transport process. But instead, we're not going to utilize a concentration gradient, we're using a pressure gradient, an area of high pressure pointing towards an area of low pressure. While diffusion is more important for the exchange of solutes between the blood and the interstitial fluid, bulk flow is going to focus on being a much more important regulator that controls the volumes of the blood and the interstitial fluid. This slide will list the two major types of bulk flow, which just refer to the movement of substances along their pressure gradients in different directions. Filtration takes things out of the capillaries, and reabsorption brings things back into the capillaries. More specifically, we can define filtration as pressure-driven movement. This is movement facilitated by a pressure gradient that points from high to low. And the specific direction is from the blood capillaries into the interstitial fluid. Oftentimes, once the substance has made its way into the interstitial fluid, it will then diffuse into our tissue cells afterwards. And reabsorption is just the opposite. We're still going to go from an area of high pressure to an area of low pressure. However, these substances will move from the interstitial fluid into the blood capillaries themselves. There are four types of pressures that will regulate bulk flow. Two of them are in favor of filtration and facilitate filtration, and the other two facilitate the movement of blood back into the capillaries, namely reabsorption. What we first need to describe is the difference between hydrostatic pressure and osmotic pressure. Hydrostatic pressure refers to the pressure in the vessels that is facilitated by the pumping action of the heart. We can look at this similarly to how much pressure is inside of the vessels. However, there's also an osmotic pressure that we need to take into account. Osmotic pressure arises from very large proteins that can be found inside of the blood or inside of the interstitial fluid. We'll find that both blood and the interstitial fluid will both have a hydrostatic and an osmotic pressure. The blood hydrostatic pressure is the pressure inside of the vessels that push substances out of our vessels through the capillary walls. This is going to help facilitate filtration, as naturally things are going to be moving towards the interstitial fluid when the hydrostatic pressure goes up. But there's also an osmotic pressure in the interstitial fluid as well. We do typically assume that the interstitial osmotic pressure is very close to zero. So we actually don't often take it into account when doing the mathematics to determine which way things are going to be pushed. But osmotic pressure in general is facilitated by these large proteins, and the more large proteins that we have in the interstitial fluid, the greater the pressure will be. And that produces the phenomenon of pulling substances into the interstitial fluid. So the bottom line here is that both of these two pressures are going to facilitate the movement of substances from the inside of the capillaries towards the outside of the capillaries. Now, with reabsorption, we're going to reverse these types of pressures. We'll see that what's going to regulate reabsorption is the hydrostatic pressure in the interstitial fluid and the osmotic pressure inside of the blood. Just as we had hydrostatic pressure in the blood, we could also have a hydrostatic pressure in the interstitial fluid. The more interstitial fluid we have, the greater force that's going to exert on the vessels and push things into the capillaries. And as we also know that blood contains lots of plasma proteins, there will be an osmotic pressure in there as well. Both of these two pressures will create a pressure gradient that pushes substances towards the inside of the capillaries. Now, I know there's lots and lots of types of pressures here. They're all going in different directions, and this can be rather confusing. What I want you to keep in mind is that these two pressures will promote filtration, and these two pressures will promote reabsorption. And this is based upon the fact that hydrostatic pressures will push substances into other places, and osmotic pressures will pull substances towards the area of higher osmotic pressure. So it is the phenomenon of filtration and reabsorption that facilitate our last capillary exchange mechanism known as bulk flow. Now, as I have mentioned several times, the venous drainage is going to have a much lower pressure in it than our arterial tree. This indicates the necessity for valves. However, valves don't have muscles in them, and we don't regulate blood flow as much with the muscles inside of our veins. So there are a couple other ways that we can also aid in venous return back to the heart. We have two outside pumps, the respiratory pump and the muscular pump, and it is the muscular pump that is shown here. I'll discuss this one first. Deep veins that are found coursing very close to our muscles can actually be squeezed to facilitate blood flow back to the heart. You can see that with muscle contraction, we can actually squeeze on these vessels and force blood upwards towards the heart. This contraction is going to open up this valve and end up closing this valve as we force blood backwards from this portion and forwards for this portion. However, when we relax our muscles, that's going to allow the opening of this valve here at the base, and it's going to close this valve. So that's one way that we can actually propagate blood back to the heart. That's our muscular pump. Standing at rest, both your proximal and distal valves are closed. But when you contract, that's going to force blood through the proximal valve and also force the distal valve shut. Now, our other pump that we have is the respiratory pump. And this is a way that we can get deoxygenated blood back to the heart while breathing. The respiratory pump uses the same concept as the muscular pump, but it uses a different muscle in a different place. Specifically, we're going to use the diaphragm to help push blood back to the heart. During inhalation specifically, the diaphragm, which is naturally bowl-shaped, is going to flatten out and move downward. This causes the downward movement and increase in pressure of the contents in the abdominal cavity. Due to the increased pressure in the abdominal cavity, the veins in this cavity are going to be compressed, and that will force more blood from the compressed abdominal cavity into the decompressed thoracic cavity. I did not mention that as we inhale and increase pressure in the abdominal cavity, we decrease pressure in the thoracic cavity. So we're actually squeezing blood from the veins in the abdominal cavity up into the veins of the thoracic cavity during inhalation. As we exhale, that's going to push blood from the thoracic veins into the right atrium. And remember, our veins have valves, so no blood is going to flow backwards into the abdominal cavity. That is another way that we can facilitate venous blood return.